Diabetic Ketoacidosis Drug Management, a focused guide to the pharmacological management of diabetic ketoacidosis, covering insulin therapy, fluid replacement, and correction of electrolyte imbalance. Management of diabetic ketoacidosis rests on three essential pillars: insulin therapy, fluid replacement, and electrolyte correction. Insulin therapy is the cornerstone of treatment. It lowers blood glucose levels, suppresses ketone production, and gradually corrects the metabolic acidosis. Fluid replacement addresses the severe dehydration that occurs due to osmotic diuresis. Restoring intravascular volume improves tissue perfusion and helps reduce blood glucose concentration. Electrolyte correction, particularly potassium replacement, is crucial. Although serum potassium may initially appear normal or elevated, total body potassium is usually depleted. As insulin therapy begins, potassium shifts back into cells, increasing the risk of hypokalemia. Together, these three interventions, insulin, fluids, and electrolyte management, form the foundation of successful diabetic ketoacidosis treatment. Insulin is the cornerstone of diabetic ketoacidosis treatment. It lowers blood glucose, suppresses ketone production, and reverses the metabolic acidosis. By stopping ongoing ketogenesis and promoting glucose utilization, insulin directly corrects the underlying metabolic disturbance responsible for diabetic ketoacidosis. Regular insulin is the insulin of choice in diabetic ketoacidosis because it can be administered intravenously and has predictable pharmacokinetics, allowing precise control of blood glucose and ketone levels. Traditionally, treatment begins with an initial IV bolus of 0.1 units per kilogram. This is followed by a continuous intravenous infusion at a rate of 0.1 units per kilogram per hour. The goal is a gradual reduction in blood glucose while safely suppressing ketone production. As blood glucose falls to around 200 milligrams per deciliter, the insulin infusion is continued, but the rate is reduced and glucose-containing fluids are added. This prevents hypoglycemia while allowing insulin therapy to continue until ketoacidosis has completely resolved. Severe dehydration is a hallmark of diabetic ketoacidosis due to excessive fluid loss from osmotic diuresis. Immediate intravenous fluid replacement is therefore essential. It restores circulating volume, improves tissue and kidney perfusion, and helps reduce blood glucose levels. In fact, fluid therapy alone can significantly lower glucose during the initial phase of treatment, making it a cornerstone of diabetic ketoacidosis management. Fluid replacement in diabetic ketoacidosis is typically started with 0.9% saline. During the first hour, 1 to 1.5 liters are infused rapidly to correct severe volume depletion. After that, fluids are continued at about 500 to 1000 milliliters per hour, with the rate adjusted according to the patient's hydration status and clinical response. Careful monitoring helps achieve effective rehydration while avoiding fluid overload. Potassium replacement is essential in diabetic ketoacidosis because insulin drives potassium into cells, causing serum potassium levels to fall. Even when the initial potassium level appears normal or high, total body potassium stores are usually depleted. To prevent hypokalemia and cardiac arrhythmias, potassium chloride is commonly added to intravenous fluids, typically 20 to 30 milliequivalents per liter when serum potassium is within the normal range. Regular monitoring is crucial throughout treatment. Bicarbonate therapy is rarely used in diabetic ketoacidosis. In most patients, acidosis corrects with insulin and fluid replacement alone. Routine bicarbonate administration is not recommended because it may cause complications such as hypokalemia. It is reserved for severe life-threatening metabolic acidosis, typically when the arterial pH is below 6.9. Even then, it serves only as a temporary supportive measure while definitive treatment addresses the underlying problem. To summarize, successful management of diabetic ketoacidosis depends on 4 key principles. First, insulin is the cornerstone of therapy. Intravenous regular insulin lowers blood glucose, suppresses ketone production, and corrects metabolic acidosis. Second, fluid replacement is urgent. Most patients present with severe dehydration, and rapid administration of normal saline restores circulating volume and improves tissue perfusion. Third, potassium must be monitored closely. As insulin drives potassium into cells, serum potassium can fall rapidly. Timely potassium replacement helps prevent potentially life-threatening arrhythmias. Finally, bicarbonate therapy is rarely required. It is reserved only for patients with severe metabolic acidosis, typically when the arterial pH falls below 6.9. Remember these four take-home messages. Insulin corrects the metabolic problem, fluids restore circulation, potassium replacement prevents complications, and bicarbonate is used only in exceptional circumstances.